Here are my disclosures. Within my talk, I will not talk about the treatments which have been licensed, but more so about the strategies going forward, and what to do in the future in particular. We've made huge advances in hepatitis B treatment. When I did my PhD studies in the early 90s, we had only interferon, and hepatitis B could hardly be treated. Yet here now, 25 years later, we can get more than 95% of the patients in remission. We can, as Pietro pointed out, reduce the amount of liver cancer. We can improve survival. So we've come a very far way, and we've done pretty well. The problem is, however, can we ever cure hepatitis B? So, as I just mentioned, we do have very successful treatments in our hands, where the long-term outcome is really improved. PEG interferon is effective in a subset of patients. It's hardly prescribed here in North America. It is not an easy drug to use at all. When we were developing treatments for hepatitis C, we didn't have a lot to fall back onto. So we had a lot of back-to-the-wall patients. That is not the case with hepatitis B. Most of our patients are suppressed by antivirals and do pretty well. So let's say the starting point for new treatment is different, and we have to come up with something very safe and very good in the field of hepatitis B. So why is finite therapy still a goal for hepatitis B treatment? I think there are many younger patients who find it difficult to accept lifelong therapy. There are women who want to become pregnant. There's long-term adherence issues. We know from any kind of therapy that a fair number of patients don't take their drugs so well. There's cost savings involved. If we have to treat for many, many decades, that will be very expensive. There's working days lost for hospital visits as well. So if we can really achieve a cure, that would give us a lot of benefits for sure. So what can we consider as defined as a cure? Because that is one of the tough discussion points of today. What is actually a cure? And we really don't know that very well, to be honest. So you could talk about virological cure, which is elimination of CCC DNA, undetectability of HBV DNA, off-therapy S antigen loss, disease cure. Do we just want to get a state where we don't get any cancer or liver failure anymore, as Pietro just mentioned? It is really unclear. What is clear, though, is that the paradigm of treatment for hepatitis B is clearly changing. We will move on, hopefully, from an indefinite therapy to a finite treatment duration. Currently, we have very poor off-treatment responses, and we're aiming for something where we would have sustained off-treatment response with a shift towards true immune control and S antigen seroconversion. We want to reduce overall mortality. Currently, we can reduce but not eliminate the full risk of HCC. And we would like to have treatments where we wouldn't get any HCC at all anymore. As I just mentioned, nukes can suppress but not cure the disease. And we have this, I think, this opportunity, particularly now that hepatitis C is a solved problem, to move into the field of hepatitis B and try to achieve cure there. So what is mostly used, and we recently had a combined meeting of EASL and AASLD on how to define cure and what endpoints to use, and I'll use some of the slides that I gave there as well in my presentation. And what is, I would say, currently the consensus is that complete cure, which is on the right, is very, very difficult to achieve. So this would be a total eradication of CCC DNA from the liver, S antigen seroconversion, obviously, hopefully associated with clinical disease benefit. And because that is so difficult to achieve, most of the experts have moved into defining cure as functional cure, which is at least something which is happening in the natural history of the disease. We do have these patients who become S antigen negative, and we know from many, particularly older studies, that these people have a much better prognosis. And this is, as I mentioned, off-treatment HBV DNA suppression, disease remission, S antigen seroconversion, and not CCC eradication, but rather inactivation or reduction of CCC DNA. Which I would think is more feasible than achieving a complete cure. If we would have reached that state of functional cure, there will be still risks for people being treated with immunosuppressive agents that the disease might relapse, but this is a very small minority of patients, obviously. So during the day, you'll hear about all kinds of new treatments which are being developed. We can interfere at different stages of the viral replication cycle for entry inhibition, CCC DNA degradation, different immune modulators, small interfering RNAs to get the S antigen level down, or other antigens if that would be preferable. Capsid inhibitors, and HBs antigen release inhibitors. There's all different steps that you'll hear about today, which I think are very interesting potentially to combine, because it might be very difficult to get functional cure just with one agent. We're now seeing the first results coming out of different studies of TLR agonists, therapeutic vaccination, small interfering RNAs, and most of them give a rather modest decline or a rather modest response rate. HBV is a very tough nut to crack. It's integrated into the viral genome, and it might be it might really be needed to combine agents. So one of the questions is what is the best endpoint here? So which biomarkers should be used? And biomarkers should be predictive. They should have a high specificity and sensitivity. They should be reflective of a durable response, high reproducibility. They should be non-invasive, preferably rapid, simple, and inexpensive. Currently, we use ALT normalization, HBV DNA decline or undetectability, S antigen, E antigen loss and seroconversion, reduction of necrosis and inflammation, and sometimes combined, and then it's mostly E antigen, DNA, and ALT. There are pros and cons of the different markers that we currently use. HBV DNA has become a very strong endpoint, particularly with the development of the nucleoside analogs. It was very pushed by industry at that time as well. And there are now several studies, or actually a lot of studies, which really show and reflect that low HBV DNA is associated, or an undetectable HBV DNA by current standards is associated with a better prognosis in our patients. The question is, to what extent do we need quantitative E antigen? It might be a bit more indicative of immune control than HBV DNA. If the HBV DNA goes down, it does give, at least with the current agents, very little assurance of off-treatment sustained response. The problem with quantitative E antigen, it can only be used particular in E antigen positive patients. So a lot of companies and a lot of people are now let's say, trending towards using quantitative S antigen, which is to be used both in E positive and in E negative patient, and which is thus far, and I know there are other markers coming, but is thus far, I would say, the most indicative biomarker for sustained immune control. If we look at endpoints, I think it is important to realize what type of study we're dealing with, because there are phase 2 or phase 3 studies, which I'll come back to in a minute. We could look at primary and secondary endpoints. We could look at antiviral versus immune modulatory drugs. We could treat patients who are really treatment naive or patients who have been treated for a long time. There's really two indications which are kind of separate. We have new patients coming in, but we have a huge warehouse of patients who have been treated for years or even decades with antivirals now, I would say, or at least more than a decade with antivirals, and yet who don't reach that point of cure. The question is what to do with these patients as well. The timing and the endpoint assessment is very important on or off treatment, and particularly efficacy criteria for further drug development. And if you look at the phase 2 and phase 3 studies, phase 1 is obviously in volunteers, and particularly phase 2A and phase 2B are important here. You reach for the optimal dose and then the efficacy, and then you move on to bigger studies where you really have to have, good evidence in phase 2 studies that this drug works enough to move it on to a phase 3 studies, which are typically very expensive and big studies for registration purposes. If you look at a survey which was done in the meeting I just mentioned, recently held in Washington, and if you ask people what are the best surrogate markers of HBV cure, and obviously this is very rough brushstrokes, there's just a couple of options that people could choose from. The best endpoint for cure by most of the respondents, and the respondents are coming like half from academia, the other half from industry, and then there's a rest group, but overall people pretty well educated in this field of hepatitis B cure, I would say. Most people think that S antigen seroconversion would be the best endpoint, followed by S antigen loss or S antigen decline. So within the different treatment modalities, as I mentioned, we really have to distinguish what type of patients we're treating. And if you divide the group of patients who are treatment naive versus those who are suppressed, typically the patients who are treatment naive are a bit younger, they have active disease. Their HBV DNA can be used as a biomarker, and not so for the suppressed patients. They don't have resistance. And they may be more likely to accept finite therapy. The suppressed patient is a very different category. They have safe and effective therapy where we know reduces HCC and improves survival. The benefit of pre-treating with antivirals is that you might induce a partial immune restoration, where patients may benefit from if you introduce immune-modifying therapy. We know whatever type of drug you use to get the viral load down, that there is a partial immune restoration. There have been several studies now done introducing, for instance, PEG interferon after nucleoside analogs. It hasn't really shown any additional benefit, unfortunately. Yet it is an interesting concept to consider for all of the new drugs, particularly immune-modifying drugs, which are being developed at the moment. These patients might have potentially better protection against flare, but also some of them have more objections to accept experimental therapy. They've been on these drugs for, as I said, many years. They have seen their FibroScan score going down. They know that their ALT and there is normal HBV DNA is undetectable. And all of a sudden we come in with an experimental drug kind of uprooting their life. So it is, and some of these patients say, well, doctor, when can I stop the nukes? That is your ideal category to use for this particular study. But it is sometimes difficult for us to convince people to be enrolled in studies of adding on new agents to nucleoside analogs. Should the endpoints differ based on the treatment modality? That is a very interesting question, and I would say in principle rather not, because all HBV treatments aimed at the common clinical goal, and the association with the clinical endpoint is essential. In other words, you could say, well, my drug works very good in reducing HBV RNA, but not in S antigen, or whatever, which I would say for a proof of principle would be fine. But at the end of the day, if every company comes up with their own endpoints, it's going to be a big mess. So it is important that guidelines for endpoints are being developed. And with the meeting which was held recently, they will be published. Still, I would say with different modes of actions, it is interesting, particularly in phase 2 studies, in proof of concept studies, to use different primary or secondary endpoints, because it might show that a specific drug works on a specific endpoint, reflecting a specific site in the viral replication cycle. And particularly if you combine drugs, that might be very worthwhile to know, obviously. It is important also to mention that indeed, depending on the treatment, the endpoint might not be the same. And I give here the example in the third bullet point of S antigen loss with RNA interference. If you give a small interfering RNA and you just block S antigen production, the patient might become S antigen negative, and everyone appears to be happy. But once you stop that drug, the S antigen might very quickly bump up again because you have not potentially induced an effective immune response at all, which is a completely different S antigen loss as the one that we see in the natural history of the disease or interferon treatment with an effective immune response. It's kind of the problem of the chicken and the egg here. Here are some examples of that from studies done by my own group. If you give an antiviral, your HBV DNA will go down much more quickly than if you give PEG interferon here on the left side of this panel. However, if you give interferon, you get a much, I would say, better decline of S antigen than if you give a nuke like entecavir. Another example of different responses here is this study where we, as I just mentioned, pre-treated patients with entecavir. Everyone was treated for half a year with entecavir and then randomized to either continue on monotherapy with entecavir or adding on PEG interferon. And this study, published by one of my PhD students last year, or actually more than a year ago now, showed that if you add on, you have a higher response rate, which is defined as E antigen loss and normalization to ALT and an HBV DNA below 2,000, than if you just continue with monotherapy, which is an interesting concept, but still 90% is rather low, and we want to be that much higher, obviously. The more interesting part of this particular study is if you look at the sustainability of the response induced by the combination, it appeared to be much higher in our patients than the response as induced by the nuke alone. So depending on a specific drug, there is also a specific sustainability of response here in this particular case. So endpoints differentiation based on clinical study phase. I already mentioned the proof of concept, which is particularly relevant for phase 2A and 2B. Dose finding, safety, very important, on and off treatment efficacy. In phase 3, the aim would be much more to really reach functional cure, to compare it to standard treatment, and the response is probably more relevant to take that off therapy. What about other potential viral and immunological endpoints or biomarkers that we are, which are coming up at the moment? There are several of those, and particularly with the revival of interest of treatment for hepatitis B, there's also a revival of interest in biomarkers for hepatitis B. Fuji Radio, a company from Japan, is working on core-related antigen, which we have tested in several of our patients, and which wasn't, at least from a clinical viewpoint in PEG interferon-treated patients, not more predictive for response than S antigen quantification. There's companies working on HBV RNA in serum. The difficulty is really how to quantify cccDNA in the liver, which is a huge challenge. First of all, you have to go into the liver. Secondly, to quantify it and to standardize it is not easy at all. People are working on S antigen epitope mapping. And there's also different immunological markers where companies are currently working on. And I think it's fine to use these markers again in your phase 2 studies to see if something is happening with a specific drug, if the drug is active, but it's really too early to use these markers for phase 3 studies because they have not been validated towards a beneficial outcome for the patients in terms of better survival, etc. So these new kids on the block, I think they need further standardization and validation. Association with clinical outcome is preferred for further use. They are, however, of interest for dissecting the mechanism of response in treatments targeting host or virus. So, in conclusions, ladies and gentlemen, I think nukes are effective, they're safe, they might be less easy to replace than we think. Nevertheless, I think it's important to shift towards an endpoint of true immune control, functional cure, and S-antigen seroconversion. You'll hear about different compounds today. HBV entry inhibitors, small interfering RNAs, capsid inhibitors are promising but in early development. Direct cccDNA inhibition is a very interesting concept but extremely hard to reach, I would say, in the near future. And the question is, do we need only antiviral agents, or do we really need the combination of an antiviral and an immune modifier? And really, there's a lot of debate ongoing there. People say, well, if you just block the viral replication at different steps with the nuke, with the capsid inhibitors, at the end of the day, if you treat long enough, you'll cure your patients. Where others say, well, no, you do need some kind of tickling of the immune response to achieve immune reactivity and eventually get immune control over the virus. So within immune modification, people are working on different mechanisms. I just named a few here: TLR agonist, therapeutic vaccination, and checkpoint inhibiting, and combination therapy might be needed. My personal view is that quantitative S and HBV DNA will be the most important biomarkers used for endpoints in phase 2 and phase 3 studies. That endpoints might differ in patients who are naive or suppressed. That endpoints may not have the same meaning for different drugs, and that for proof of concept studies, phase 2 studies, different validated endpoints can be used in different compounds depending on their mechanism of action, also to allow future combination therapy. Thank you very much for your attention. You're in Toronto now, and in 2 years from now, I hope you'll be again in Toronto, because then we will host the IHVLD, the Global Hepatitis Summit, here in this very nice city. Thank you very much.